Fibromyoma, leiomyoma, fibroma, or fibroids are the commonest benign neoplasm arising from the uterus. They are commonly seen in women of reproductive age group. Incidence varies from 5 to 20% in women depending upon the age group. A myoma is derived from the smooth muscle cell rests either from the vessel wall or the uterine musculature. Although estrogen, progesterone, growth hormone, and human placental lactogen have been implicated in the growth of myoma, the evidence in support of estrogen and progesterone dependence for their growth is impressive. Because they are rarely found before puberty and generally cease to grow after menopause. New myoma rarely appear after menopause. Pathology. Grossly, myoma is a well-circumscribed tumor with a whorled appearance and a pseudocapsule. It is firm in consistency. The cut surface is pinkish white and has a whorled appearance. The capsule consists of connecting tissue which surrounds the tumor in the myometrium. The vessels that supply blood to the fibroid lie in the capsule and send radical branches into the tumor. Because of this arrangement of the blood supply, central portion of the fibroid receives least blood supply, and degeneration is noticeable early and most often in this part of the fibroid. On the other hand, calcification begins in the periphery, spreads inwards among the vessels. The vessels are best seen over the subserous myoma, where in case of large intramural growth, they have been beneath the peritoneal covering of the uterus. This serves to distinguish the enlargement of the uterus due to a myoma from a normal intrauterine pregnancy. Microscopically, the tumor consists of bundles of plain smooth muscle cells separated by a varying amount of fibrous strands. Areas of embryonic muscle tissue may be present in the myoma. The tumor may grow symmetrically, remaining within the myometrial wall when it is called intramural or interstitial. If the tumor grows outwards towards the peritoneal surface, it shows itself as a bossy growth and is termed subserous. In rare cases, a tumor gets attached to a vascular organ and is cut off from its uterine origin. Then it is called parasitic fibroid. Uterine contractions may force the myoma towards the cavity where it is covered only by a thin endometrium. It is then called submucous myoma. This myoma may force itself downwards towards by vagina by a pedicle and becomes a submucous myomatous polyp. The distribution is intramural 75%, submucous 15%, subserous 10%. Cervical fibroid. It accounts for 1 to 4% of all fibroids. These may develop as a central, anterior, posterior fibroid or grow laterally in the broad ligament. Pseudo-Meek syndrome. Pedunculated fibroid can cause right-sided hydrothorax, ascites, mimicking malignant ovarian tumor. This is known as pseudo-Meek syndrome, and this disappears spontaneously following the removal of the tumor. Symptoms of fibroid. A cervical fibroid exerts pressure on the bladder, ureter, and in rare cases on the rectum. A woman may feel a lump in the lower abdomen. During pregnancy, it can cause retention of urine. Obstructed labor can occur if the cervical fibroid lies below the presenting part. In the other clinical features are those of uterine fibroid. Other sites of fibroid. Broad ligament fibroid. They are mostly uterine fibroid which extend laterally in the broad ligament. Rarely, fibroid may arise de novo within the broad ligament, either from the wall of the vessel or some other structure, and then they are called true broad ligament fibroid. All the fibroid from uterus extending into the broad ligament displaces ureter vessels laterally and downwards. True broad ligament fibroid displaces ureter and vessels medially and upwards. Round ligament fibroid. Occasionally, fibroid may arise from round ligament. Ovarian ligament fibroid. Fibroids attached to the ovarian ligament may arise from this structure but uncommon. Parasitic fibroid. When a fibroid is found in a structure such as omentum or surface of intestine, they may arise from uterus. Subsequently, because of the blood supply from these structures, lose their attachments to the uterus and may arise from omentum or intestine. Secondary changes in the fibroid are atrophy. As a result of diminished vasculature after menopause, there is shrinkage in the size of tumor which becomes firmer and more fibrotic. A similar change may occur in myomas after delivery. When a tumor is easily palpable during pregnancy, may be difficult to define. Temporary shrinkage by 50% following gonadotropin releasing hormone therapy, but it regrows after stoppage of therapy. Hyaline, cystic, fatty degeneration that occurs in the central areas of the fibroid are of no clinical significance and are caused by diminished vasculature in large fibromyoma. Secondary changes and complications. Hyaline, cystic degeneration and atrophy. Calcareous degeneration, osseous degeneration, red degeneration, sarcomatous changes, torsion, hemorrhage, infection, ulceration, particularly in the dependent part of the submucous polyp, inversion of the uterus, endometrial carcinoma associated with fibromyoma, endometrial and myohyperplasia, accompanying adenomyosis, parasitic fibroid. Calcareous degeneration. Phosphates and carbonates of lime are deposited in the periphery along the course of the vessels. The best example is seen in old patients with long-standing myoma. They are like womb stones in graveyards. Calcareous tumors are easily identified on plain X-ray film of abdomen. Red degeneration. This complication of uterine myoma develops most frequently during the pregnancy, although it is not rare in cases of painful myomas in women older than 40. The myoma becomes tense, tender, and causes severe abdominal pain, with constitutional upset and fever. The tumor itself assumes a peculiar purple-red color and develops a fishy odor. If the tumor is carefully examined, some of the large veins in the vessel and the small vessel in the substance of the tumor will be found thrombosed. The discoloration is possibly caused by diffusion of blood pigments from the thrombosed vessel. Histologically, apart from the thrombosis, no specific appearances have been identified. Little is known of exact etiology, and particularly as of when only myoma is involved and not the myometrium. Although the patient is febrile with moderate leukocytosis and raised ESR, the condition is an aseptic one. It needs to be differentiated from appendicitis, twisted ovarian cyst, pyelitis, accidental hemorrhage. Pseudomyx syndrome. A pedunculated fibroid may cause right side hydrothorax and ascites mimicking malignant tumor. Removal causes automatic regression. Sarcomatous change in myoma is extremely rare and the incidence is not more than 0.5%. Intramural and submural tumors have higher potential for sarcomatous changes than subserous tumors. It is rare for malignant change to develop in a woman younger than 40 years. Other complications like torsion. A subserous pedunculated myoma may undergo rotation at the site of its attachment to the uterus. As a result, the veins are occluded, tumor becomes engorged with blood. Very severe abdominal pain is experienced. In very rare cases, the rotated tumor may adhere to adjacent viscera, obtain a fresh blood supply from these adhesions, and finally gets detached completely from the uterus. The so-called wandering fibroid or parasitic fibroid. Inversion. Inversion of uterus caused by submucous fundal myoma has been described. Capsular hemorrhage. If one of the large veins on the surface of the subserous myoma ruptures, profuse intraperitoneal hemorrhage can cause acute hemorrhagic shock. Infection is common in submucous myomatous polyp if they project into the cervical canal or the vagina. An infected polyp can cause blood-stained purulent discharge. Infection is more likely in the postpartum and post-abortal state. If the tumor causes delay postpartum hemorrhage or sepsis, it may have to be removed. Associated endometrial carcinoma is seen in women older than 40 years in 3% of the cases. Hyperestrogenism explains the coexistence of these two conditions. Symptoms of fibroid. Menorrhagia, polymenorrhagia, metrorrhagia, continuous or postmenopausal bleeding, infertility, recurrent abortion. Pain, pressure symptoms, abdominal lump, vaginal discharge. As many as 50% women are asymptomatic. Intramenstrual disturbances. Progressive menorrhagia seen in intramural and submucous myoma is due to increased vascularity, endometrial hyperplasia and enlarged uterine cavity. Further away from the cavity, lesser is the possibility of menorrhagia. Hence, subserous and pedunculated fibroid do not cause menorrhagia. Polymenorrhea occur when cystic ovaries, pelvic inflammatory disease coexist with fibromyoma. Metrorrhagia is a common with submucous fibroids. An infected polyp will also cause purulent discharge. Metrorrhagia in women older than 40 years require dilatation and curettage to rule out endometrial carcinoma. Infertility. Fibroids may be responsible for infertility. Infertility is either due to associated PID, endometriosis, or anovulatory cycles, or due to distortion of the uterine cavity causing obstruction to the sperm ascent, poor nidation, corneal tubal block. A fibroid larger than 4 cm can cause infertility. Submucous myomas are more likely to be responsible for infertility and recurrent pregnancy loss in up to 20% cases. Pain and dysmenorrhea. Most women complain of heaviness in the lower abdomen. Congestive and spasmodic dysmenorrhea is often symptom of fibroid or associated pelvic disease. A submucous fibroid often causes spasmodic dysmenorrhea. Acute pain is seen when a fibroid is complicated by torsion, hemorrhage, and red degeneration. Pain in a rapidly growing fibroid in an elderly woman may be due to sarcomatous change. Pressure symptoms. Anterior and posterior fibroid in the lower segment or cervix can increase in frequency and retention of urine. More often premenstrually because premenstrual congestion results in enlargement of the fibroids. Broad ligament fibroids can cause hydroureter, hydronephrosis, changes which are reversible following surgery. Constipation and intestinal obstruction are rare, but if it occurs due to a loop of intestine adherent to the fibroid. Abdominal lump. A large fibroid may present as an abdominal tumor which has been growing slowly over a long period. A rapid growth only occurs during pregnancy due to oral contraceptive hormones and malignancy. A pedunculated fibroid feels separate from the uterus and gives the impression of an ovarian tumor. Other symptoms are due to anemia such as dyspnea and palpation. A rare condition of pseudomic syndrome has been described with a pedunculated fibroid causing ascites and right hydrothorax. Vaginal discharge. Acute medical condition. An acute clinical condition associated with uterine fibroid are acute retention of urine, acute abdominal pain with red degeneration of fibroid during pregnancy, retention of urine, torsion of pedunculated fibroid, hemorrhage, infection, sarcomatous change causing severe abdominal pain, rare cause of thromboembolism. Physical signs like anemia may be noted. A abdominal lump may be felt arising from the pelvis with well-defined margin, firm consistency, smooth or bossy surface. Tumor is mobile from side to side unless fixed by its own large size, adhesion or by broad ligament fibroid. Ascites is rare. By manual examination we reveal enlarged uterus, regular or bossy depending upon number and size of fibroid. Cervix moves with the movement of the mass which is not felt separate from the uterus unless it is pedunculated. In a cervical fibroid, the normal uterus is perched on top of the fibroid. A broad ligament fibroid displaces the uterus to opposite side. In a myomatous polyp, the cervical os is open and its lower pole is felt. The uterine fundus cannot be palpated if inversion is associated with fundal submucous fibroid polyp. The uterus is uniformly enlarged. In submucous fibroids, intravascular disseminated peripheral fibroids rarely exist but are often diagnosed only at laparotomy. Differential diagnosis can be mistaken for pregnancy. A cystic degenerated fibroid causing a soft enlarged uterus may be mistaken for pregnancy. Hematometra caused by cervical stenosis causing enlarged uterus, secondary amenorrhea. Adenomyosis shares the same clinical features as uterine fibroid. Uterus of more than 12 weeks size or an irregularly enlarged uterus favors diagnosis of fibromyoma. Bicornuate uterus, endometriosis, ectopic pregnancy, chronic PID, ovarian tumor, chronic inversion, full bladder, bilateral tubo-ovarian masses, pelvic endometriosis, endometrial carcinoma, uterine sarcoma, ovarian neoplasm, para-ovarian cyst or pelvic kidney are the differential diagnosis suspected uterine fibromyoma. Investigation. Hemoglobin blood group are required. Ultrasound. A fibroma shows a specific feature of well-defined round tumor, hypoechoic with cystic spaces if degeneration has occurred. Ultrasound can also identify adenomyosis as a diffuse growth with intramural cystic spaces, ovarian tumor, ectopic and adnexal mass. Hysterosalpingography. Sonosalpingography identifies submucous myoma and to check the patency of fallopian tubes in presence of infertility. Hysteroscopy not only identifies a submucous polyp but also allows its excision under direct vision. DNC is required to rule out endometrial carcinoma. It is necessary in women complaining of menstrual disorder and post-menstrual bleeding. Laparoscopy is required in a rare situation such as inversion of uterus while excising a myomatous polyp to detect PID and endometriosis. Radiology has been superseded by ultrasound. Calcification as a peripheral calcified area is also seen in certain ovarian tumors. TB mass, calcified mucocele of appendix, bony tumor. MRI is very useful in virgins. Old women when pelvic examination clinically is not desirable in the former. Hysteroscopy may be difficult due to narrow cervix. CT scan is not very useful but MRI is accurate in identifying adenomyosis and sarcoma. Treatment. Small and asymptomatic uterine fibroid do not require removal or medical treatment. They can be observed every 6 months. It is needless to emphasize that malignant lesion should be ruled out. Diagnosis of fibromyoma should be certain. During pregnancy, surgery is contraindicated except in case of pedunculated fibroid if it undergoes torsion. Acute retention of urine is treated by continuous catheterization for 48 to 72 hours. When the growing uterus rises above the pelvic brim, red degeneration merits conservative treatment. Similarly, myomectomy is not advisable during caesarean section because of uncontrolled bleeding that may ensue, except for a pedunculated fibroid. Indications for treatment in asymptomatic fibroid are infertility caused by cornual fibroid blocking the tube, habitual abortions due to a submucous fibroid. Other causes of infertility and abortion should be ruled out. A fibroid of more than 12 weeks size and a pedunculated fibroid which can cause torsion. An asymptomatic fibroid causing pressure on the ureter, that is broad ligament fibroid, pressure on the bladder, leaving residual urine and causing urinary infection. Rapidly growing fibromyoma in a menopausal woman implying impossible malignancy. When the nature of the tumor cannot be ascertained clinically. All symptomatic fibroid. Expected management, wait and observe for 6 months for growth. Medical management, non-surgical like uterine artery embolization and MRI. Minimally invasive surgery and major surgery. Advantages of the medical method are it avoids anesthesia and surgical risk, cures menorrhagia, controls anemia, cures the pressure symptoms. It reduces the size of the tumor and blood supply, therefore less operative bleeding, allows phalansteal incision. It allows laparoscopic myomectomy by reducing vascularity and size. Side effects of the drugs. Disadvantages are side effects do not allow treatment over indefinite period, like in GnRH therapy. Failure of treatment, recurrence of symptoms after stoppage of the treatment. Surgery may be still required. Advantages of surgery are it removes the fibroid, cures the symptoms in one setting, improves fertility in 40% cases. Risk of malignancy is eliminated. But the disadvantages are risk of anesthesia and surgery, bleeding and trauma, risk of post-operative adhesion, recurrence of fibroid due to growth of seedling fibroid occur in 5 to 10%, persistence of menorrhagia in 5 to 10% due to congestion and large uterine cavity. Management of uterine fibromyoma. In asymptomatic women, observation with regular follow-up if the size is less than 12 weeks, in uncomplicated pregnancy with fibroid, surgery if size is greater than 12 weeks, or cornual fibroid causing infertility, pedunculated cornual fibroid, pregnancy with torsion of pedunculated fibroid. Symptomatic treatment like medical treatment, hormones to shrink the fibroid, uterine artery embolization, myomectomy, lap myolysis, MRI guided ablation, total abdominal hysterectomy, vaginal hysterectomy, total laparoscopic hysterectomy, lap hysterectomy, laparoscopic assisted vaginal hysterectomy are done in symptomatic cases. Cervical. In 1% of the cases, vaginal polypectomy or myomectomy, laparoscopic myomectomy, MRI guided myolysis, vaginal hysterectomy, total abdominal hysterectomy. GnRH therapy. GnRH analogs used for 6 months reduce the size by 50 to 80%. This treatment in premenopausal women and young women with infertility may eliminate the need for surgery. It is also useful in reducing vascularity besides size preoperatively, and by causing amenorrhea or reducing menorrhagia restores the hemoglobin level. Shrinkage of fibroid allows phalansteal incision in the abdominal operation, minimal invasive surgery or a vaginal hysterectomy instead of an abdominal hysterectomy, and also reduces bleeding. Monthly depot injection of 3.6 mg should not be extended beyond 6 months. One should remember that the tumor can regrow after stopping the drug. Instead of monthly injection, 3 monthly leuprolide acetate 11.23 mg may be convenient to administer. Pure anti-estrogen Faslodex may be effective for the same purpose. These hormones, however, do not relieve dysmenorrhea. Other anti-estrogens such as raloxifene, aromatase inhibitor, fadrazole are under trial. The disadvantages of GnRH therapy are fibroid capsule may thin out, making enucleation rather difficult. Small fibroids may become invisible at the surgery but recur later. Mirena IUCD can be used to control menorrhagia and dysmenorrhea due to fibroid. Add-back therapy with OC pills, tibolone, progesterone with GnRH can reduce the side effect and allow longer use of GnRH. GnRH antagonists are better than agonists as they avoid the initial flare-up effect and act faster. Surgery. Myomectomy. Myomectomy refers to the removal of fibroid, leaving the uterus behind. It is indicated in infertile women or a woman desirous of childbearing and wishing to retain the uterus. It is done by open surgery, laparoscopically or vaginally, or through hysteroscopic route. Preoperative requisites. Hemoglobin should be restored. Autotransfusion arranged in few days before surgery is preferred to donor transfusion. Infertility. Other causes of infertility should be excluded. Signature for hysterectomy is required in difficult unforeseen circumstances. Myomectomy should be performed in pre-ovulatory menstrual cycle to reduce the blood loss during surgery. Endometrial cancer should be ruled out by DNC. Bowel preparation avoids bowel injury. Technique of myomectomy. Opening the abdominal cavity by phalansteal incision is possible if the uterus is less than 16 to 20 week size and is mobile. If difficulty is anticipated with a large uterus, fixed uterus with adhesion, associated PID, endometriosis, a vertical paramedian incision is safer. Care should be taken not to injure the bladder while incising the parietal peritoneum, as the bladder may be elevated in cervical low-lying anterior wall fibroid. The pelvic organ should be carefully inspected and the feasibility of myomectomy confirmed. An incision over the anterior uterine wall is performed whenever possible, as many fibroids removed through minimal tunneling incision. Hemorrhage should be controlled with the myomectomy clamp. The clamp should be applied from pubis end of the abdominal wound, and the round ligament, which will include the uterine vessel, should be gripped. The ovarian vessels may be temporarily occluded with a sponge forceps. If the myomectomy clamp cannot be applied as in cervical fibroid, a rubber tourniquet will serve the purpose. Local injection of dilute vasopressin also helps to reduce the blood loss. The capsule should be incised, the fibroid enucleated. This will minimize the bleeding and avoid trauma to the bladder and urethra. Myomectomy screw help during enucleation. Following enucleation, the hemostasis is secured and the cavity obliterated with several catgut suture. This will avoid scar rupture during subsequent pregnancy and labor. The clamp should be released. Hemostasis confirmed. The raw visceral area should be well peritonized to prevent postoperative adhesion. Hydroflotation also reduces adhesion. The uterus remains bulky following myomectomy, requires to be antiverted by plicating the round ligament with non-absorbable sutures. Result: pregnancy of rate of 40 to 50% has been reported following myomectomy. Pregnancy loss has been reduced. However, 10 to 15% continue to suffer from menorrhagia. Recurrence of fibroids in 5 to 10% cases is due to overlooking seedling fibroids at the time of surgery. The complications that may result from myomectomy are primary, reactionary, secondary hemorrhage, trauma to the bladder, ureter, bowel during surgery, infection, adhesions, intestinal obstruction, recurrence of the fibroids, persistence of menorrhagia. Vaginal myomectomy. It is indicated in submucous fibroid polyp. Vaginal myomectomy is possible in cervical fibroid, pedunculated fibroid polypus, and if more than 50% submucous fibroids project into the cavity. Hysteroscopic myomectomy has become possible for submucous fibroids not removable easily by vaginal route. The fibroid is excised either by cautery, laser, or resectoscope. It is best done under laparoscopic guidance to avoid uterine perforation. Complications are cervical trauma, uterine perforation, thermal injury, bleeding, infection, failure, uterine adhesion, water overload, or pulmonary edema due to distending media. Laparoscopic myomectomy is possible in pedunculated fibroid, subserous fibroid not extending 10 cm in size, not more than 4 in number. Multiple fibroids of any size should be approached by laparotomy. Unipolar, bipolar cautery, and laser have been employed to remove the fibroma and obtain hemostasis. The fibroma is retrieved to posterior colpotomy, mini laparotomy, or by morcellation. Disadvantages are more bleeding because of non-applicability of hemostatic clamp. Being an adhesogenic procedure, it takes longer to perform. Postoperative adhesions can increase the infertility rate. Scar rupture is reported in late pregnancy and during labor. Some use interseed oxidized regenerated cellulose to prevent or reduce adhesion. The major complication is rupture of myomectomy scar. Uterine artery embolization. Improvements in symptoms cancel definitive surgery in some cases. Menorrhagia was relieved in 80 to 90%, pressure symptoms in 40 to 70%, volume decreased by 50% at the end of 3 months, by 60% in 6 months, 75% at the end of 1 year. Contraindications are subserous and pedunculated fibroid. Necrosis and fall of tumor into peritoneal cavity can occur. Big fibroids are not used for UAE. Submucous fibroid is not cured. Infertility rate may increase following this technique because of post-embolization pelvic adhesion. Calcified fibroid cannot shrink with this technique. Associated inflammatory disease may also preclude the employment of this technique. Under local sedation, bilateral uterine artery is approached through percutaneous femoral catheterization. It is done using polyvinyl alcohol, gel foam particles, or metal coils. Embolization reduces vascularity, the size of fibroid in 3 to 4 months. Pregnancy should be postponed for at least 6 months. Symptoms are relieved in 70 to 80% of the women. Complications are fever, infection, vaginal discharge, bleeding, ischemic pain suggest successful therapy but can be unbearable and require analgesia. Pulmonary embolism, ovarian failure, fertility rate is reduced due to adhesion. Failure due to inadequate embolization caused by arterial spasm or tortuosity of the vessel. Expulsion of fibroid into peritoneal cavity. Allergic reaction and contrast-induced renal failure. Radiation exposure. Hematoma at the femoral site. Extrusion of subserous fibroid into peritoneal cavity which requires retrieval. Intraperitoneal adhesion. Proper selection of the patients is a key to clinical success and avoiding complication. A follow-up with ultrasound 6 months later is also necessary to observe the shrinkage of the fibroid. Other indications for UAE beside fibroid are arteriovenous aneurysm, increased uterine vascularity causing menorrhagia, postpartum hemorrhage. Placenta accreta to reduce the bleeding before placental removal or caesarean delivery. MRI focused ultrasound. The following advantages of UAE are: there is no major surgery required, no intraoperative bleeding, short hospital stay, less abdominal adhesion, 75 to 80% women are satisfied. MRI focused ultrasound. It is also a non-invasive technique, uses high intensity focused ultrasound beam that heats and destroys fibrous tissues. MRI guides in targeting the beam path towards the fibroid. A large fibromyoma can be retreated in 2 sessions, or the fibroid is reduced in size with monthly GnRH injection for 3 to 4 months before the treatment. Side effects are skin burn, pain, nerve damage is rare. Advantages are non-invasive technique, local anesthesia, no hospitalization is required, no scar, quick recovery, fertility preservation technique. Contraindication: calcified fibroid, degenerated fibroid. Laparoscopic myolysis. This is an optimal surgery using Nd:YAG laser, Cryoprobe, diathermy to coagulate a subserous fibroid. Hysterectomy. Hysterectomy means the removal of uterus which is indicated in women older than 40 years of age, a multiparous woman, or when associated with malignancy. Uncontrolled hemorrhage and unforeseen surgical difficulties during myomectomy may also necessitate the hysterectomy. Types of hysterectomy are abdominal, vaginal, laparoscopic. Abdominal hysterectomy include total hysterectomy, subtotal hysterectomy when the cervix is retained, panhysterectomy when done with bilateral salpingo-oophorectomy when the ovaries are also removed. Extended and Wertham's hysterectomy in case of cancer cervix and uterine cancer. Advantages of subtotal hysterectomy are cervix is retained for sexual function, normal cervical discharge is beneficial, vault prolapse is less common, less bleeding, less risk of bladder ureter trauma. In a difficult surgery, total hysterectomy may increase the surgical morbidity due to trauma to the bladder, denervation, causing difficulty in micturition and incontinence. Pap smear before the ovaries ensures that the cervix is normal. In benign condition, ovaries should be retained to avoid menopausal symptoms in premenopausal women, provided they look normal. Disadvantages of conserving the ovaries are benign and malignant ovarian tumor may develop in 1% cases. Residual ovarian syndrome is known to occur in some cases and cause dyspareunia. Atrophy of the uterus has been reported due to kinking of the ovarian vessels within 3 to 4 years of hysterectomy. They may become non-functional and cause early menopause. TAH, total abdominal hysterectomy. It is straightforward in most cases of fibroid. However, in case of cervical, low anterior wall and a posterior fibroid, one engorging into the broad ligament where bladder, ureter, rectum are displayed from their normal anatomical position. They are at risk of injury. In a cervical and large anterior wall fibroid which is close to the bladder, it is prudent to perform myomectomy first. This allows a clear view of the vaginal vault, safeguard against the bladder injury. Thereafter, hysterectomy can be performed. Similarly, in a low posterior fibroid, the upper segment of the broad ligament may not be accessible until the fibroid is first enucleated. In central cervical fibroid, a huge posterior fibroid, hemisection of the uterus and enucleation of the fibroid will allow safe hysterectomy. Vaginal hysterectomy is possible if the uterus is mobile, uterine size is less than 14 weeks with no previous surgery or there is no other pelvic pathology. In all other cases, abdominal hysterectomy is performed. Ovaries may be conserved in women younger than 50 years of age provided they are healthy. Vaginal hysterectomy is not a good approach in nulliparous patient with narrow vagina. Lately, vaginal hysterectomy is being done for uterus more than 12 week size provided uterus is not fixed by adhesion, adnexal inflammation mass or endometriosis. Previous laparoscopy to confirm the presence or absence of pelvic adhesion, size of uterus rule out pelvic pathology. Bisection of uterus and removing each half separately. Myomectomy and enucleation of the fibroid first, then morcellation. Laparoscopic assisted vaginal hysterectomy. This avoids abdominal scar, minimizes abdominal pain, shortens recovery period and hospital stay. Contraindications are uterus more than 14 to 16 week size, fibroid located in the broad ligament, cervical fibroid and extensive pelvic adhesion, and endometriosis. Complications of hysterectomy: primary, reactionary and secondary hemorrhage. Trauma to the bladder, ureter, bowel may occur in the cervical and broad ligament fibroma. Sepsis, anesthetic complication, paralytic ileus, intestinal obstruction due to postoperative adhesion, thrombosis, pulmonary edema, chest infection, burst abdomen, hernia, postoperative infections such as wound infection, peritonitis, pelvic infection, and embolism. Chronic pelvic pain. Abdominal adhesions can cause chronic abdominal pain, dyspareunia, vault prolapse, residual ovarian syndrome, atrophy of the ovaries due to decreased vascularity causing premature menopause in 2 to 3 years, ovarian cancer in 1% if ovaries are left behind during the hysterectomy, urinary dysfunction due to denervation of bladder, granulation tissue at the walled prolapse of the fallopian tubes. Flowchart of fibroid uterus. First we'll do the history, examination and ultrasound, abdominal and transvaginal. For asymptomatic fibroid, we follow up every 6 to 12 months using ultrasound and treat if the size is greater than 12 weeks, there are pressure symptoms or there is infertility with no other causes explaining. If the symptomatic fibroid, menstrual problems, are treated with hemostatic agents. In young patients, hormone pills, Mirena, uterine artery embolization, myomectomy are considered. In older women greater than 45 years, TAH is done. If infertility is there, then myomectomy is done. For pressure symptoms in young patients, myomectomy is done. For greater than 45 years old, hysterectomy is done.